This is Dr. Goodin with Panic Anxiety and Their Disorders. Anxiety involves a general feeling of apprehension about future danger, and fear is an alarm reaction that occurs in response to immediate danger. Anxiety disorders share symptoms of clinically significant fear and/or anxiety. Anxiety is often manifested in physical symptoms and may have previously been called a neurotic disorder by Freud, who explained it as intrapsychic conflict. Fear and anxiety differ by the true amount of danger present. With anxiety, danger may be true but less clear or obvious. Fear is a basic emotion with adaptive value. When fear response occurs in the absence of obvious external danger, we call this a spontaneous or uncued panic attack. Panic attacks resemble fight or flight response but are accompanied by a sense of impending doom, fear of dying, going crazy, or losing control. Fear and panic have three symptoms: cognitive, subjective, physiological components, and behavioral components. Anxiety is a complex blend of unpleasant emotions and cognitions oriented to the future and is more general. Anxiety is adaptive, helps us plan and prepare for possible threat. It may enhance performance and learning with mild to moderate degrees. Sources of fear and anxiety are often learned or conditioned. An example would be the noise of an abusive father's car coming up the driveway. Anxiety disorders have unrealistic, irrational fears or anxieties of disabling intensity as their principal and obvious manifestation. Anxiety disorders vary by importance, quantity, and types of anxiety sources. Examples would be specific phobia, social phobia, panic disorder, agoraphobia, generalized anxiety disorder, and obsessive-compulsive disorder. Genetic vulnerability via personality trait of neuroticism is a proneness or disposition to experience negative mood states. Note that the limbic system is part of the brain that deals with emotions. Social environment may make people more or less vulnerable based on the amount of uncertainty in the environment. There are similar treatments across anxiety disorders. Examples include graduated exposures, cognitive restructuring techniques, which help individuals understand distorted thought patterns about the anxiety-related situations and how the patterns can be changed, and then medication, anti-anxiety or antidepressant meds. Specific phobia is a phobia that is persistent and involves disproportionate fear of some specific objects or situation that presents little or no known actual danger and leads to avoidance of the feared situation. It is a strong and persistent fear that a person realizes is excessive or unreasonable and is triggered by the presence of a specific object or situation. It often results in a panic attack. Avoidance is a dominant characteristic of dealing with a phobia due to anxiety. Blood injection, injury phobia, adds disgust to the fear mix. Increased heart rate followed by dramatic drop in heart rate and blood pressure, where fainting is common. Phobias are more common in women. In terms of psychological causal factors, we have the psychoanalytic perspective, where phobias represent a defense against anxiety that stems from repressed impulses from the id. It is too dangerous to know the repressed id impulse, so anxiety is displaced onto an external object or situation with symbolic relationship to the real object of anxiety. From behaviorists, we have classical conditioning that says phobias are learned or conditioned due to a traumatic experience. Vicarious conditioning tells us that fear or phobia results from viewing another person having a phobia response. Individual differences in learning play a role. Life experiences make us more or less vulnerable to phobias. Lifetimes of good experiences with a dog before being bitten will change our response to how much anxiety we feel as a result of being bitten. The inflation effect suggests that a person who acquires a mild fear of driving following a minor crash might develop full-blown phobia if he or she was physically assaulted with no automobile present. Cognitions can increase or decrease the phobia risk. Evolutionary history affects which stimuli we are likely to fear. Prepared learning, built on the concept that ancestors who acquired fears of true threats had a selective advantage. Thus we fear spiders more than motorcycles. In terms of biological causal factors, we have genetic and temperamental variables that affect the speed and strength of conditioning of fear. Think about behaviorally inhibited toddlers, maybe excessively timid, shy, easily distressed. They have a higher risk of phobia. In terms of treatments, a behavior therapy known as exposure therapy is often used. Controlled exposure to the stimuli or situations that elicit the phobic fear. The clients are gradually placed symbolically or under real-life conditions in the situations they find most frightening. The client exposes the self to feared situations as long as possible to help the fear subside. Participant modeling may also be used, where the therapist calmly models ways of interacting with the phobic stimulus or situation. Social phobias are characterized by disabling fears of one or more social situations, such as public speaking. They have a fear of scrutiny and potential negative evaluation of others and/or that they may act in an embarrassing or humiliating manner. They either avoid or endure the situation with great distress. Generalized social phobia involves significant fears of most situations and is non-specific. Onset of social phobia is usually during teen years or adulthood, whereas specific phobias are normally during childhood. Drug abuse is common to ease anxiety. Think about going to the bar and using alcohol as liquid courage. Social phobics have lower employment rates and lower socioeconomic status. Social phobia may result in a panic attack. They may have learned or conditioned directly or vicariously through experiencing or witnessing perceived social defeat or humiliation, and often have parents who are socially avoidant. Note that the social phobic involves fear of one's own species, not snakes or predators necessarily. So evolution may have something to say about this. Social fears and phobias evolved perhaps as a byproduct of dominance hierarchies, usually formed through aggressive encounters, wherein defeated individuals displayed fear and submission. Angry faces are more easily conditioned, and they activate the amygdala, which is our fear center. Social phobia is associated with lower perceived personal control. In terms of cognitive biases, we have danger schemas of socially anxious people that lead them to expect negative results, that they will behave awkwardly or in an unacceptable fashion, resulting in rejection and loss of status. Social phobics' inward attention and somewhat awkward behavior may lead others to react less friendly, confirming their expectations, and this is a self-fulfilling prophecy. Social phobics tend to interpret ambiguous social information in a negative way rather than neutral. There are some biological causal factors I want to mention. Predisposition due to temperamental variable, aforementioned behavioral inhibition. Treatments may involve behavior therapy and cognitive behavior therapy, such as cognitive restructuring techniques. A therapist may attempt to help clients identify underlying negative automatic thoughts, which are cognitive distortions. They may use logical reanalysis to challenge automatic thoughts and modify distorted self-images. Medications may also be used, MAOIs, SSRIs, or beta blockers. Panic disorder is defined and characterized by the occurrence of panic attacks that often seem to come out of the blue. Diagnostically, it must have recurrent, unexpected attacks and must have been persistently concerned. A person must have been persistently concerned about having another attack or worried about the consequences of having an attack for at least a month. This is called anticipatory anxiety. Panic attack in most DSMs, check your current DSM-5, normally is diagnosed with 4 out of the 13 possible symptoms being met. 3 of those are cognitive symptoms. Note that panic attacks are often mistaken for heart attacks. People often end up in the hospital thinking that they have had a heart attack. Agoraphobia comes from the word agora, which is a Greek word for public places of assembly. Agoraphobia describes when the most commonly feared and avoided situations include streets and crowded places such as shopping malls, movie theaters, and stores. Agoraphobics are anxious about being in places or situations from which escape would be physically difficult or psychologically embarrassing, or in which immediate help would be unavailable if something bad happened. They are also frightened by their own bodily sensations, so they avoid any arousal at all. Scary movies, sexual activity, drinking caffeine, or even exercising. It's rare to have agoraphobia without panic attacks, and agoraphobia is more common in women. The first panic attack they have normally follows feelings of distress or highly stressful life circumstances, the loss of a loved one, loss of a relationship, a job, anything like that. Genetic causes involved temperament trait of neuroticism, as we've mentioned before. Physiological causes may include increased activity in the amygdala that plays a central role. The amygdala is a collection of nuclei in the front of the hippocampus in the limbic system of the brain that is critically involved in the emotion of fear. It's the center of the fear network. Panic disorder would occur when the fear network is too sensitive. There are also biochemical abnormalities. Noradrenergic activity in certain brain areas can stimulate cardiovascular symptoms associated with panic. Serotonergic activity decreases this, thus SSRIs are used to combat panic disorder. In terms of psychological explanations, we talk about learning. Anxiety becomes a conditioned response to internal or interoceptive conditioning and external or exteroceptive conditioning cues. And these cues may be heart palpitations, galvanic skin response, and think of a galvanic skin response as the chills or goosebumps that you might get when the hair on your arm stands up straight. That's a galvanic skin response. They have anxious apprehension of another attack and anything that may cause the attack. The cognitive theory of panic is that sufferers catastrophize bodily sensations and their automatic thoughts then trigger the panic. Note that nocturnal panic attacks can also occur, and this supports the idea, the psychological theory of learning over the cognitive theory, which is meaning-oriented. People with higher anxiety sensitivity are more prone to develop panic attacks or disorder. Anxiety sensitivity is a trait-like belief that certain bodily symptoms may have harmful consequences. Perceived control over the body and circumstances plays a crucial role in panic and agoraphobia. Many people feel better or safer if they have a safe person near them. That could be a parent or a friend. However, due to all their precautionary measures, their safety behaviors, they attribute the lack of a true catastrophe to their caution. Thus, their caution is reinforced. Treatments in terms of medication, are anxiolytics, which are anti-anxiety medications, usually from the benzodiazepine category. Think of Xanax or Klonopin. And they increase symptom relief and overall functioning. They're tranquilizers. The drugs act quickly, especially if taken under the tongue, which is sublingually. They may cause drowsiness, sedation, slower cognition, or slower motor performance. They may also lead to physical dependence and have risks associated with withdrawal. Medical doctors fear abuse and are hesitant to prescribe. Antidepressants have little physiological dependence. They help with depression, but they take normally 4 weeks to reach effective levels, and they often have a lot of side effects. There's also behavioral and cognitive behavioral treatments. Exposure therapy was first used, then interoceptive exposure, meaning deliberate exposure to feared internal sensations. Also cognitive restructuring using panic control treatment, an approach that targets both agoraphobic avoidance and panic attacks. GAD, or Generalized Anxiety Disorder, is anxiety and worry about many different aspects of life, including minor events, that become chronic, excessive, and unreasonable. People with GAD have anxious apprehension, they are constantly worried and upset, they ruminate and obsess. They have difficulty making decisions and worry about errors in their decisions. It's twice as common in women, and they often use self-treatment, such as alcohol abuse. Causes from a psychoanalytic perspective are that there is an unconscious conflict between the ego and the id impulses that is not adequately dealt with because the person's defense mechanisms have either broken down or have never developed. More likely to have perceptions of uncontrollability and unpredictability, which are more stressful and create more fear and anxiety. There's no tolerance whatsoever for uncertainty. So think about your own life. How well do you tolerate uncertain situations? Uncertainty means feelings of unsafety, no safety signals unless the territory is known. The worry process is central in generalized anxiety disorder, since worrying calms the person's arousal. It makes them feel in control, and it is reinforced, even if the target of the worry does not deserve attention. Worry may lead to thinking about all possible negative outcomes. And here we have a key word, intrusive thoughts. Intrusive thoughts are usually negative, and they're thoughts that intrude, despite being unwanted and or unwelcome. For example, a person on a plane may wish to avoid thoughts about the safety of the plane during takeoff. A jealousy-prone husband may be tortured by imagined images or thoughts of his wife with another man. Note that trying to control worry only elevates worry. Anxious people have a bias toward threatening cues and negative information. There is some genetic root in this, and that genetic root is comorbid with depression. Same roots in neuroticism. Anxious people have a functional deficit in GABA, serotonin, and norepinephrine. Corticotropin releasing hormone system and anxiety issues also play a role. CRH stimulates the release of ACTH from the pituitary gland, which causes release of stress hormones or cortisol from the adrenal gland. Cortisol helps the body deal with stress. In terms of treatments, we have Xanax, Klonopin, or buspirone is a newer, less sedating or addictive drug, but it takes 2 to 4 weeks to work. Cognitive behavioral treatment is also used, usually with applied muscle relaxation and cognitive restructuring techniques aimed at reducing distorted cognitions and information processing biases and reducing catastrophizing. Obsessive-compulsive disorder is defined by the occurrence of unwanted and intrusive obsessive thoughts or distressing images. It's usually accompanied by compulsive behaviors performed to neutralize the obsessive thoughts or images or to prevent some dreaded event or situation. Obsessions involve persistent or recurrent intrusive thoughts, images, or impulses that are experienced as disturbing, inappropriate, and uncontrollable, whereas compulsions can involve either overt repetitive behaviors that are performed as lengthy rituals, think of hand washing, or more covert mental rituals, such as counting. People count tiles on the roof or cracks in the sidewalk. They have rigid rules as to how to perform the behavior. They know it is a compulsion from within rather than an external source or voice, as in schizophrenia, and this is how we differentiate the two. So I want to point out that we all have some obsessions and compulsions. We all can act obsessively or compulsively. It doesn't mean we have the disorder. But think about your own obsessions and compulsions. When have you acted compulsively? When have you bought something that perhaps you shouldn't have bought? When have you not been able to turn your mind off and kept thinking or ruminating about something? And what's the difference between just having sort of a thread of a disease as opposed to the full disease? Obsessive thoughts include contamination fears, fears of harming self or others, or pathological doubt. The need for symmetry may be there. Sexual obsessions, religious obsessions, or even aggressive obsessions. People with OCD feel compelled to perform acts repeatedly that often seem pointless and absurd even to them, and that they, in some sense, do not even want to perform. There are 5 primary types of compulsive rituals: cleaning, checking, repeating, ordering and arranging, and finally counting. Performance of compulsive acts or ritualized series of acts usually brings reduced tension and satisfaction as well as a sense of control. It makes interpersonal, occupational functioning difficult and may lead to divorce or joblessness. Again, this is comorbid with depression due to the lifestyle it requires, and sometimes comorbid with body dysmorphic disorder. So think about how conditioning could possibly explain obsessive compulsive disorder. If you were to see shaky hands on a doorknob, that could be scary and could somehow be associated with the need to wash hands, and that washing of hands relieves tension. OCD is associated with preparedness, a fear of sickness, dirt, and contamination. It may have evolutionary roots in that way. There are also possible cognitive causes. Suppressing obsessive thoughts is difficult to do. There's the paradox of don't think about white bears. This is the most typical thought suppression example. And of course, when you tell somebody not to think about something, it's even more difficult. Suppression increases intrusive thoughts by twice as much. People with OCD feel responsible for more. They feel that having a thought about doing something will hurt someone, or is equivalent to having done it. That is called thought-action fusion. They have an inflated sense of responsibility about the possible harm that they could cause, and that makes the harm even more awful. It leads to more compulsions to reduce the likelihood. There are also biological causes, genetic predispositions for OCD, cortical and subcortical structural abnormalities, the basal ganglia, which is linked to the amygdala, high levels of activity in 2 areas of the orbital frontal cortex, more than usual, where primitive urges seem to reside: sex, aggression, hygiene, and danger. The urges are normally filtered by the cortico-basal ganglionic thalamic circuit. Serotonin overabundance are helped by the SSRIs that downregulate and help serotonin not to increase. In terms of treatments, exposure and response prevention are used. OCD clients develop a hierarchy of upsetting stimuli and are asked to rate them on a 100-point scale according to their capacity to evoke anxiety, distress, or disgust. Then they're asked to expose themselves repeatedly to a stimulus. They're asked to not engage in rituals or compulsions, and they learn that nothing horrible happens and anxiety eventually subsides. Of course, homework is often used in behavioral therapy. In terms of medicines, Prozac and Afrinil or even antipsychotics may be used. Neurosurgery can be used if nothing else works. After 5 years of debilitating OCD, it's possible. There are sociocultural factors of anxiety. The USA is highest for anxiety disorders, whereas the Ukraine and China are lowest. Perhaps due to different goals, different problems, different belief systems, and different emphases. What people dream about, the emphasis on money. Note that there are some cultural differences that are similar. Chinese have a mental anxiety disorder called Koro, where they fear that the penis will retract into the body and that the person will die. Of course, that's for males. For women, it's a fear that the nipples will retract and that the breast will shrink. There's a similar disorder in West Africa where sexual potency is very important. The Japanese have Taijin Kaiyufusho. It's sort of like sociophobia. It's a fear of interpersonal relations or of social situations. Whereas social phobia is about embarrassing oneself, Taijin Kaiyufusho is phobia of embarrassing or offending others. They fear blushing or emitting an odor. They fear eye contact. And the fear is really about bringing shame to others, and that's what brings the social avoidance. There's a strong emphasis, of course, in Japan on guessing and being sensitive to another person's thoughts or feelings. And there's emphasis on obedience and the need to be docile. People are taught to look at the throat instead of the eyes. Looking someone in the eyes is considered aggressive. So facial communication is used to show respect for hierarchy and social status. Thank you very much. I'll see you next time.